Welcome to PAPERI Bright Minds, where we spotlight the pioneers shaping the future of genomics, public health, and cancer research. This special session, in honor of International Childhood Cancer Day, features Dr. Catherine Metayer, an esteemed epidemiologist and global leader in childhood cancer research. Dr. Metayer's work explores the genetic and environmental risk factors of childhood leukemia, uncovering how exposures to chemicals and other factors contribute to cancer development. As director of Circle and past chair of the Childhood Leukemia International Consortium, Dr. Metayer has shaped our understanding of genetic and environmental risk factors for childhood cancer.
Okay. Hello, everyone, and welcome to PAPERI Bright Minds Series, where we celebrate and learn from exceptional individuals driving advancements in genetics, genomics, healthcare, and beyond, across Africa and globally. I'm Sarah Musallam, and it's honor to have you join us today. Today, we are thrilled to welcome Dr. Catherine Metayer, professor of UC Berkeley School of Public Health Division of Epidemiology. Dr. Metayer received her medical degree from the University of Bordeaux in France and her PhD in epidemiology from Tulane University School of Public Health Division of Epidemiology. She's currently professor at the UC Berkeley School of Public Health Division of Epidemiology. Prior to joining UC Berkeley, Dr. Metayer was a scientist at the U.S. National Cancer Institute, Division of Cancer Epidemiology and Genetics. Her work primarily focuses on environmental, dietary, and genetic risk factors of childhood leukemia and testicular cancer, which disproportionately affect the Latinx communities in California. She is the director of the Center of Integrative Research on Childhood Leukemia and the Environment Cycle, and the immediate post-chair of the Childhood and Cancer Leukemia International Consortium. She collaborates with the researchers at the intersection of the various omics, including genetics, epigenetics, metabolomics, and adoptomics. In this session, we will explore Dr. Catherine Metayer's journey, their contributes to public health and epidemiology, and the lessons they have learned along the way. We will start with the question: could you share with us the key factors that drew you to study childhood leukemia and cancer, and what has been the most rewarding aspect of your research journey?
Thank you. First of all, thank you so much for inviting me to your group and platform. It's an honor to talk about my work on childhood leukemia and other cancers. My journey, it has been actually a confluence of different events. I was trained as a physician in France, and I did my fellowship in cancer departments and pediatrics departments. And when I wanted to move into research, especially cancer research, which was, a dear interest to me as a clinician, I happened to come to the United States and meet with researchers who had already started a study on childhood leukemia studies. So it was interest, but also chance to meet people who were actually doing great work, and I could start working with them.
Perfect. You led several impactful studies, including the California Childhood Leukemia Study. Could you tell us more about the study's aims and some of the major findings?
Yes, so the California Childhood Leukemia Study started back in 1995, and actually I was not the inaugural PI. It was another researcher, Professor Patricia Buffler. So the study was really a pioneer at the time, like 30 years ago. First off, we didn't know much about was causing, childhood leukemia and other cancers in children. It was mostly exposure to X-ray, some very, specific genetic syndromes among children. So little was really known about what was causing leukemia. And several, researchers around the world, including, here at UC Berkeley, started to, develop more robust studies to really investigate what were the factors that would, lead to leukemia. And the focus of the study was I would say two arms. Was to look at the environment at large. That was including exposure to chemical, but also diet, lifestyle, and genetic predisposition. So those were the two main aims of the study when it started, in 1995. But what was new then was to introduce a novel epidemiologic methods to better assess exposure. So, for example, we were conducting interview like many other studies are doing. But what was special for us is that we would go back to the homes of the families that participated in the study, and we would collect dust. And dust is a reservoir of chemicals that is, deposited for months and years, and could be a good snapshot of what the child or the mom during pregnancy would be exposed to. So we introduce novel component. What was novel too is really to bring the collection of biospecimen. So childhood leukemia, childhood cancers are rare. Those are rare disease, and the most efficient way to study the risk factors is to conduct what we call case control studies. That means identify the cases, identify healthy controls, and go back in time through interviews and novel method to interrogate what happened before. And so this is really challenging. This is extremely challenging. So the study and colleagues that work on this study, I'm definitely not the only one, really brought novel approach to try to better identify those risk factors. One was to collect blood samples that are collected at birth. Those are routinely done to identify any genetic malfunction, but we were able to access those what we call blood spots that are collected at birth to conduct biomarker studies, novel exposomic studies. We also made sure that we would collect the bone marrow and blood at the time of the diagnosis, so we could better identify the molecular subtypes of leukemia and see if specific subtypes were associated with specific risk factors. So that study, the California Childhood Leukemia study, was really novel in terms of methods. And to that day, 30 years later, colleagues and I are still using the resources that we gathered over the years.
Yes, this is a huge work, so it should be a reference. A significant portion of your research focuses on genetic and environmental risk factors for childhood leukemia. Can you explain how these factors interact and what some of the key findings from your studies?
Yeah, so I would say the key findings in terms of exposure to chemicals are, we identify that children that live in areas with high level of air pollution will be at increased risk of childhood leukemia. Children who are exposed to pesticide, whether it is at home or whether they live nearby an area where pesticide is being used, or whether the parents are farm workers and they're using pesticide. Those different sources of exposure have been associated with increased risk of childhood leukemia. We found that diet also is a very important part, which at the contrary can help reduce the risk of having leukemia. So healthy diet, fruit and vegetables will, during pregnancy would help decrease the risk of leukemia. Supplemental folate also has been found to reduce the risk of leukemia. Breastfeeding is also, protective. So we have found both, agents that will increase the risk, but also decrease the risk. Those are modifiable risk factors, and the way they act can be very different. Many of the chemicals that we have identified, like I told about pesticide, air pollution, tobacco smoke, organic compounds, many of those are actually known to cause cancer in adults. So, it's not complete surprise that it's also the same for children. The way of action of those chemicals can be multiple. They can really damage the DNA, but they can also work through other mechanistic pathways, like modifying the immune response. And therefore, for childhood leukemia, this is a very important pathway that those chemicals could be working through. In terms of genetics, I am not leading the genetic studies. I'm working with collaborators that do, but most of the findings to date are around genes that are involved in the development of the leukemic blood cells. So there has been a series of studies that have identified specific genes.
So, what steps can we take to minimize the risks of environmental exposures?
So that is a very good question. I would say that in the early years of our work, we were really focusing on identifying what are the exposure, what are the routes, who is specifically at risk. But it took us a while to really translate this information. And I was fortunate, as part of the center that I have on childhood leukemia study, to work with Dr. Miller at the University of California, San Francisco, who was leading a group that is really helping research translation and really helping to educate families, educate physicians, educate policymakers, educate researchers on what we know already and what can be done to reduce exposure to air pollution, pesticide, organic solvents, smoking. There are ways where we can train or educate families how to reduce the risk, but the burden should not be only on the families. So, the way to translate also this information is to stakeholders who can make, larger changes in the policies to reduce, for example, air pollution level in big cities. So there is definitely a large amount of work that has to be done, that we started to do with Dr. Miller, in order to really educate the population at large, to let them know we know already what can cause leukemia and some other cancers. We can start working on reducing exposure to those.
Okay. As the director of Circle, you have spearheaded groundbreaking work in environmental health. What do you see as the next big steps in the field of childhood cancer research, particularly with the respect to environmental exposure?
So I think that we've done a lot of work over the past years looking at, mostly looking at traditional tools, information from interviews, and we've learned a lot by just asking the parents, what did you do, when, and so that was kind of the big first step of all those childhood leukemia studies or childhood cancer studies. We, we discovered that, of course, that can have some limitation. And I think the next big step that is already in the work is to have a better identification, characterization of exposure to chemicals, have a more direct assessment. So, for example, we started to do this work by collecting dust samples in the homes, but still, dust sample is still an external marker of the exposure and doesn't really reflect possibly the body burden. So ideally, one wants to actually collect biospecimen of the child and the mom possibly to try to interrogate those specimen and to be more precise, because the tools we have now can really look at every molecules that are in our body, whether those are endogenous molecules, just like part of the metabolism, or those are exogenous, external chemicals that now we can identify. So those are using novel exposomic methods, exposomic studies that we are able to apply to the specimen that we collected at birth. So I think this is the next big breakthrough. These methods have really improved over the past 10 years, I would say. The identification and library of all the names of those molecules that we can identify in our body have improved and are continuing to improve. So I think this is going to be really informative to have a bigger picture of the magnitude of all the molecules that we're exposed to and which one are actually leading to childhood leukemia or childhood cancer. So that's one aspect. The other aspect is to actually account for the mixture of exposure that we are using exposed to. So there are novel methods. As we generate those data, we also need to have novel statistical method that can really deal with the magnitude of information that we are collecting.
Can you share how international collaborations such as Childhood Leukemia International Consortium have advanced our understanding of childhood leukemia?
Yeah, so that was a very important moment, I would say maybe 15 years ago, when our group realized that as much as we're doing great work, our study were still based on small numbers. And again, because childhood cancer is a rare cancer compared to adult cancers. So all the studies around the world, in the US, in Europe, in Egypt, in South America, were working with this same issue of having small sample size to which was limiting to have more conclusive, interpretation of the findings. So about, I would say 15 years ago, several childhood leukemia researchers started to, meet and brainstorm on how can we work together to really take advantage of almost similar studies. The studies were asking the same questions, had different designs, but could be combined. So I would say the breakthrough of the CLIC consortium is to bring robust findings by combining data from sometimes 15 studies around the world, and working with thousands, data on thousands of cases and thousands of controls. So really, the consortium really helps to kind of put more weight on what the individual studies have found by really combining the data and telling us, yes, the cursor is going towards an association or no association or reduction in risk with more confidence.
Your research also extends to other early onset cancers like
Rhabdomyosarcoma.
Thank you. And testicular germ cell tumors, which distinguishes the study of these cancers from childhood leukemia. And what challenges do they present in terms of prevention and treatment?
So interestingly, I've been working mostly on testicular cancer, germ cell testicular cancer in adolescent and young adults. And so what is interesting with this cancer is that, like childhood cancers or certain childhood leukemia, we know that there is likely a fetal origin of the cancer, meaning that the cancer started in utero. And this is this is special for germ cell testicular cancer, because the cancer cell is actually an original cell, embryonal cell. So I would say the commonality between studying childhood leukemia and early onset testicular cancer is actually the period of initiation and when were the first hits that then led to developing cancer later in life. What's interesting also, at least in California, is that the rates of childhood leukemia are much higher in Latino children than white children. And for testicular cancer, that was for the longest time, white young men were at risk of having testicular cancer more than other groups. But more recently, Latino men are the ones to have the highest rates of testicular cancer. So we see some kind of analogy here. And what that tells us, that when we see changes in rates in a such short period of time, most likely the environment is, contributing to that change. And so we are, the same way we are looking at chemical exposures in utero, early life for the risk of childhood leukemia, we're also focusing on early life exposures to endocrine disrupting chemicals or immunotoxic chemicals to see if they are also leading to testicular cancer much later in life. So there is actually some commonality between the two.
What are the most promising advancements in childhood cancer research that give you hope for the future?
So I think that we are definitely keeping up. We try to keep up with the technology to really improve our understanding of what type of chemicals precisely are increasing the risk. But the flip side is that most likely the phenomena leading to childhood leukemia are a combination of gene and environment interaction. And this has been quite difficult to actually identify and document, most likely because we were working with small numbers. Remember, we were each study was doing their own studies. So we were kind of facing difficulties because of the numbers that really limited our ability to do, gene environment interaction studies. Now, the other limitation was, not having a good assessment of the exposure. We're working on that, working with exposomic studies. The field of genetic epidemiology has, obviously improved over the past years, that we can now interrogate the whole genome. So I think we are arriving at the time where we are going to have all the elements for us to be in a position to better look at gene-environment interaction. And this work will definitely be done and is actually underway with the Childhood Cancer and Leukemia International Consortium, the CLIC Consortium. This is, the new initiative of the consortium is really now to bring the genetic susceptibility with the environmental factors to try to kind of detangle this aspect. So I think that's definitely the next big, big wave of research. I would say the very important part of our work, as I said, is research translation. So we have to continue to educate people as we learn more. We know a lot already, but it seems that there is a lag between what we know and the perception of what people think about what can cause leukemia. So we try to bridge this gap by doing a lot of webinar, informational webinar and seminar, putting together videos that can be available, from anywhere, developing some materials and fact sheets so people can refer to. So there's a lot of work that has to happen for research translation now, but also in the future. We have to keep up with that. And I would say a new area of research is to understand if we now know that chemicals, the environment is affecting the risk of developing leukemia, what about if this environment is also affecting the response to the treatment and the prognostic? So there are new lines of research that are trying to actually look at the childhood cancer continuum and how the environment is actually affecting a cancer patient at every step, not only at risk of having the disease, but how well the patient will respond and how well the cancer survivors will do, throughout their lives. So those are, I would say, the three new areas that needs to be, worked out for the future.
This leads us to the question of how do you envision the next generation of scientists contributing to a better understanding of childhood cancers? What advice would you give to young researchers entering this field?
So what I've learned is that there's nothing we can do if it's not with collaboration and working with people that are experts in their fields. It's actually daunting of how much one needs to know to really be able to do this work. So collaboration, I think is the key, because you always learn from people's expertise and experience. You can share your own experience, but also your challenges. And the more you talk to people and brainstorm, the more ideas you have. So I would definitely encourage the new junior investigators to work with other groups and bring their own knowledge, because it's not because we're senior investigators that we know it all, and it's really nice to have several generations working together to make progresses. So I would say go out there, meet people, work with a group. We're fortunate to have the CLIC Consortium group, and that's a great place to start.
Looking back at your career, what are some key moments or challenges that shaped your path in childhood cancer research?
I think key moments were where I became principal investigators of studies, and so as much as I was part of a group before that, and working in this field, I felt that once you become principal investigator, you have more drive and more responsibility, and always need to think creatively of what can be done now, what could be done later. So I would say, to really shift from being a junior investigator to be a more, senior investigator was kind of a very important time in my journey as a researcher. And I think I continue to have this drive and try to see what can we do next.
If you could change one thing about the approach to childhood cancer prevention and treatment globally, what would it be?
Other good question. So I'm going back to research translation, because really during my training as an epidemiologist, it was never mentioned. It seems that we were working in silo. The epidemiologists were doing their work, publishing in journals, and then move on. And it's only later during this journey of my journey of childhood cancer research that the two fields of research translation and the epidemiologists, geneticists were put in the same room to really work together and make sure that there was no long lag between our discovery and what could we do with this discovery. So I would say if something could have been done better was to work with experts in outreach and research translation sooner. And so, but I think we are caught up here in our group, but I believe that this is still something that can be improved in different curriculums, in different places, to really work hand in hand with the basic science, epidemiologic science, but also research translation.
Thank you. Thank you, Dr. Catherine Metayer, for sharing your incredible insights and experiences with us today. Your work is truly inspiring, and we are honored to have had this opportunity to learn from you today. Thank you, everyone, watching us for today's session of PAPERI Bright Minds Shaping. I'll repeat this again. Would you like to say anything before we end this session?
I'm really pleased to have met Wafa through the International Consortium. I'm really impressed by her initiatives to again bring the science that is generated in different part of the world, but bring the science to everybody. So it's hard to keep up. Everybody's busy, you clinicians, and you don't read every paper. So I think this more lively way to engage the community at large helps people to, be up to date about the science and what is being done. So I would say congratulations to your group to really being proactive with this educational lens.
Thank you so much. Thank you to everyone watching us for today's session of PAPERI Bright Minds Series. Stay tuned for more sessions featuring exceptional leaders and innovators shaping the future of science, healthcare, and education. Don't forget to follow PAPERI on its social platform for updates and upcoming events. Have a wonderful day. Have a wonderful day, Dr. Catherine.
Thank you so much. You too. Bye-bye.
Bye-bye.